this is Alessandro Pozzi from Rome, Italy, and welcome to my institute. I'm an associate professor in the University of Rome Tor Vergata, where I teach oral surgery and implant dentistry, and I'm a part-time professor in two major universities in the US, the Harvard University and the Augusta University. My working life is divided in two main parts: treating my lovely patient and conducting daily clinical research on the most advanced digital technologies in order to introduce new clinical workflow in which the fundamentals of implant dentistry are blended with the most digital advancement. Because the key is making complex treatment easy. Because this is what our patient wants. Wants predictability, but also a minimal invasive approach to try to recreate what the patient has lost. Because this is the terminal dentition patient that we are facing every day because of the global phenomenon of the aging of our population. So not only teeth and implant, but using digital to challenge the most advanced clinical protocol and to make it easier. Because the patient really want something that is very easy to understand. They want back what they have lost. And this is what I'm focusing on. Try to recreate a natural dentition from the aesthetic and functional standpoint, using all the fundamentals that I widely publish along the last 30 years, but at the same time updating the fundamentals with the most advanced technology that make our treatment journey easier and most likely more predictable with less complication for our patient. Welcome to my surgical theater. And please, I want to share with you, the technology that we have in this operative room. Because every day we deal and we face the difficulties of the complete arch patient. And this is the most advanced clinical situation that really deserve digital technology to try to simplify complex clinical protocol. And that's why today in my media loading procedure, I'm using daily an advanced iOS scanner because this is Shining 3D. Please come with me and follow me. So when we deal with media loading, unfortunately, we are not dealing with the stable anatomy because we are taking an impression during the surgery. So we don't have the proper landmark that must be stable to detect the surface, the anatomy of the patient. So unfortunately, right after the implant placement, we have the bleeding, we have an open wound, we have the flat mobility. All these aspects can bias the conventional iOS scanner, even though the Shining 3D scanner is characterized by a very large field of view and the scanning depth that can enhance in just one 3D scanning the detection of multiple landmarks in just one 3D image. However, we need to go further because what is the current scanning in the surgical theater deserve a further technology, an advancement in the conventional iOS scanning. And this is the IPG technology. IPG technology is using something that is completely different. It's using dedicated scan body that are detected not with a surface optical scanning, but are detected using coded geometry. These small dots are identified a specific geometry. So the IPG or intraoral photogrammetry through the same iOS scanner is detecting this dot. And through these dots is connecting the scan body geometry on the top of the multi-unit. So this type of procedure is completely different from conventional iOS, and is completely different from conventional extraoral photogrammetry. You know why? Because at the end of the workflow, we don't have only the implant coordinates disconnected by the patient anatomy, but we have just one digital file in which the implant coordinates are connected with the patient anatomy. And that is something amazing, because to facilitate the superimposition between the implant coordinates and the patient anatomy, we are using a further hybrid intraoral photogrammetry protocol in which iOS and the IPG are working together through this vertical scan body that are similar to the horizontal scan body because are characterized by these dedicated dots. And this hybrid step allow to perfectly superimpose the capturing of the implant coordinates through the IPG with and the superimposition of these coordinates with the patient anatomy. The end results is one data set of file in which what we plan in advance, soft tissue, walks up, and what we achieve right after the implant placement, so the capturing of the implant coordinates, can be shared to the restorative software. So it means that in the restorative software, we don't need any further digital manipulation, but we have one data set that is ready to be transformed in a file to print out in about 20, less than 30 minutes, an immediate temporary prosthesis. This technology is escalating, is advancing our immediate loading, because I don't want anymore to convert a prosthesis that is prefabricated, connecting with a temporary cylinder in the patient mouth. But I'm using an intraoperative scanning to fabricate a brand new monolithic prosthesis with a terrific accuracy. You see the fitting of this tie base on the top of multi-unit. That it's a unique protocol combining the accuracy of intraoral photogrammetry with the easy production of a brand new monolithic prosthesis that is 3D printed and delivered in the patient mouth in 1 hour. When we come up to full arch digital impression, this is one of the most controversial topics in digital dentistry, because there are still doctors around the world that are taking a full arch impression in an analogic manner. And this is why they are not really confident about the performance of the digital impression. However, it's about 10 years that we are widely validating different types of technology available in the market for full arch digital impression. And we recently published a systematic review with a very solid meta-analysis on the clinical implant dentistry and related research journal, in which we clearly demonstrated that the photogrammetry technology outperformed the iOS technology in terms of accuracy when we come up to trueness and precision. So no doubt about that. When we need to take a full arch impression, we need to go to photogrammetry technology. However, photogrammetry, it's available in the market with different technology. We have the extraoral or conventional photogrammetry, and we have brand new intraoral photogrammetry. And this type of technology, if the name is pretty similar, the clinical outcome is completely different. We publish so far the clinical performance of extraoral photogrammetry or conventional photogrammetry. And even though this technology, in respect to the IO scanning, it's far superior, however, we experience deviation, extreme deviation, that are far above the limits, the threshold limits for achieving a passive fitting restoration. That's why more recently we investigated a completely brand new technology that is the Shining 3D intraoral photogrammetry. And this technology is a really breakthrough because it's combining in the same device the clinical advantages of the IOS scanning with the superior accuracy of the photogrammetry technology. And moreover, there is another major difference. With conventional photogrammetry or extraoral photogrammetry, we can only capture the implant coordinates that are floating in the air. And thereafter, we need to superimpose to the digital file coming from the IOS scanning. Indeed, with the intraoral photogrammetry, the final digital data set that we can achieve at the end of the digital scanning, it's just one file, one data set of file combining the surface scanning coming from the IOS with the superior accuracy of the photogrammetry impression of the full arch implant scanning. So when we come up finally to translate this number in vivo, what we can achieve, and this is the latest investigation that we have recently submitted. Intraoral photogrammetry in the patient mouth is showing an accuracy that is absolutely terrific, positioning intraoral photogrammetry at the highest standard of accuracy for full arch digital impression, with the mean deviation of about less than 7 microns on the z-axis, about 4 microns, even less in the x-axis, and about 10 microns in the y-axis. And with a mean angular deviation of 0.3 degrees. This type of clinical performance will allow us to produce directly from the digital file coming from the intraoral photogrammetry the definitive restoration without any type of prototype testing. And you see that the accuracy of this full arch zirconia framework on zygomatic implant, so very challenging scenario for photogrammetry, the accuracy in terms of seating, it's terrific, very passive, without any type of micro movement. And you can see the overall seating at the interface of the multi-unit abutment that is absolutely impressive. I want to spend a few words on a very important aspect of the digital dentistry. That is the practicality of the digital technologies. My team, it's a very young team. We have PhD students and we are dental students. Alessandro is going to be graduated in a few months and is managing all the digital file coming from the patient. And let me tell you that, the file coming from the Shining 3D technology are very easy of use. And that represents a huge difference because we don't need to be super expert to use this technology. It's a very friendly technology that can be easily transferred in any type of software. Now Alessandro is, using and moving the digital information in the laboratory software or in the software for the 3D evaluation of the clinical performance of Shining 3D. And what we experience, Alessandro, are terrific clinical performance with the deviation on the x-axis, how many microns?
3.7 microns.
It's about 4 microns. On the y-axis,
10.
10 microns. On the z-axis,
Less than 7.
less than 7. This is a terrific technology, not only in terms of accuracy, but also in practicality and the ease of use.